Welcome to Voices of Wentworth. My name's Kath Naish, and I'd like to start by acknowledging that we're on the land of the Gadigal people of the Eora Nation, and by paying our respects to their elders, past, present, and emerging. I'd like to welcome our speakers today, Professor Andrew Carr, Director of HIV and Immunology at St Vincent's Hospital in Sydney, and Professor Kerryn Phelps, one of Australia's best-known doctors and public health and human rights advocates, former president of the Australian Medical Association, and of course, the former federal independent member for Wentworth. Thank you both for joining us to pick up from our town hall event in June, which was on the subject of the COVID pandemic, when we heard from epidemiologist Professor Mary-Louise McLaws, Macquarie Bank Chief Economist Rick Deverell, and aged care advocate Craig Gear. And for anyone who's not yet seen that expert-led discussion, it can be viewed on our YouTube channel or via our website. Well, a lot has happened since then. We have had a major COVID outbreak in Sydney. Millions of Australians are back in lockdown and could be forgiven for having absolutely no idea of what is going on due to the confusing messaging we are constantly bombarded with, whilst also trying to work from home, keep in touch with friends and family, and homeschool our kids. So we hope that you will be able to clear up some of these questions for us. We keep hearing from government politicians that the vaccine rollout is accelerating and record levels of vaccinations are being achieved. What they tend not to focus on is the delays to the vaccine rollout due to lack of supply, rising numbers of cases, deaths, hospitalizations, ICU admissions, and those on ventilators, which continue to paint a grim picture of the realities of this pandemic. Certainly since our town hall event in June, the rate of vaccinations has increased, which is obviously a good thing. But a Guardian Essential poll this week provided some key insights into the views of Australians about the shortage of supply of COVID vaccines, vaccine hesitancy, and concerns from the majority of respondents that lockdowns and other restrictions should continue until a substantial proportion of children are fully vaccinated. So Andrew, you're going to take us through this all in a bit more detail, and I'll hand over to you.
Thanks very much. And good afternoon, everybody. I will just share my screen, hopefully. Over the next 20 minutes or so, I'll try to give a very brief highlights tour, if you like, of coronavirus vaccination. Very good. So if we just look at a few key numbers of where we are in the epidemic at the moment. On the left, you'll see that as of yesterday, we have had 218 million confirmed cases of COVID worldwide, or about 2.8% of the world's population. Almost 100 million of those cases are confined to just 3 countries, the United States, India, and Brazil, whereas Australia has had, on a global scale, relatively few cases of 56,000 confirmed cases, or just over 0.2% of our population. In the bottom left, you'll see the cases per day over the last 18, 19 months, starting with just 32 cases a day at the end of January last year, and now having an average of about 610,000 cases a year. In terms of deaths on the right-hand side, there's been 5.5 million confirmed deaths, but there's estimated that there's at least another 6 million undiagnosed deaths, bringing us up to about 11.5 million deaths, or just under 0.2% of the population, with currently about 9,000 deaths a day. If you look at history, for comparison, the Spanish flu gave us about 50 million deaths at a minimum, or 2.5% of the global population. And the Black Deaths, which started in the 1300s, ended up killing at least 75 million adults in Europe, West Asia, and North Africa, or 30% of that population. So historically, we are not by any means the largest pandemic. So how do we prevent COVID? You'll see this is the so-called Swiss cheese model of disease prevention, or in fact, the prevention of any bad outcome. For example, the airline industry uses a similar model, where you erect a number of barriers between a target, as seen on the right-hand side, the person, and something like a bullet heading towards that target. We recognise that all potential barriers are imperfect, hence the holes in the cheese. So if you erect enough barriers, that sooner or later, if it goes through several holes in the barrier, it'll soon hit a barrier where there is protection. And so along the top is a series of barriers between COVID and a human, which includes distancing, masks, hand hygiene, not touching my face, limiting your time in crowds, ventilation, and of course on the far right, quarantine and vaccination. Some of those are more sort of the personal responsibilities, and some of those are a more shared responsibility. So why do we vaccinate against anything? I think it's always good to sit back and think about why we do what we do. Of course, we're doing this to prevent illness, hospitalizations and deaths, to prevent forward transmission, and to prevent long-term consequences. So in the case of COVID, many people will have heard of the term long COVID, which I won't have time to discuss. Additionally, for COVID and other pandemics, we're doing it to prevent lockdowns and to allow free movement, to allow normal business activity and employment, and of course to minimise the government and societal debt that accrues as you deal with the pandemic. So where are we up to in terms of the effectiveness of the vaccines that we have, namely AstraZeneca and Pfizer, and the vaccines that we're likely to see in the next few months, Moderna, and then the Novavax. Importantly, so each of these vaccines went through a large-scale clinical trial. These are called phase 3 clinical trials, where you treat tens of thousands of people with either the vaccine or a placebo vaccine. And from those, you'll see on the second line, the protection from the vaccine from illness. And at the end of the vaccine study, which varied for technical reasons between 7 and 15 weeks, the vaccine of efficacy of AstraZeneca was 70, maybe 75%, Pfizer was 95%, and Moderna and Novavax also 90% plus. There is now some less concrete data to suggest their protection against the Delta variant with a little longer follow-up is something around the 70% to high 80% mark. Pfizer has published its data about its protection 6 months after the vaccine, the second dose of the vaccine, and the 95% figures become 84%. Importantly, AstraZeneca has not published its 6-month post-vaccine data, which sort of makes me feel a little uncomfortable. It would be great to see those data in the public domain. The top line that I'll go to next is what's the protection from any infection? And that's not been reported by these studies, but large-scale population rollouts suggest the protection from any infection, so symptomatic illness and asymptomatic infection, is about 65 to 90%. But again, that's quite short-term follow-up. Most importantly, as I've highlighted in the blue at the bottom, is the protection from hospitalisation and death. So without wanting to sound callous in any way, I don't really care if somebody gets a mild flu-like illness, but I care very much that people don't get hospitalised and people don't die. And the protection in these studies from hospitalisation and death was very close to 100%. So I have put question marks there because the studies weren't absolutely large enough to confirm that, but no one who got the real vaccine in these 4 studies died. Now, of course, one of the big issues in many people's minds this year has been the vaccine safety, in particular the AstraZeneca vaccine and its association with a very rare form of blood clot, most commonly observed in the brain and the belly. And this is an unusual form of blood clot. It's not due to physical immobility, as you might get from lying in a hospital bed or sitting on an airplane for 24 hours. It's in fact an overactive immune response induced by the vaccine that provokes clotting. The frequency of any clot depends on your age, and it's higher if you're younger. In Australia, if you age less than 60, the risk is about 1 in 37,000 doses. If you're older than 60, it's 1 in 62,500 doses. The death rate from the clot is about 1 in 1.2 million doses. So I find my patients find those numbers very abstract. So if you turn to 1 in 37,000 doses, that means if I really wanted to give you a clot, I'd have to give you the vaccine every day for just over 100 years. So the risk really is very low. Turning to the Pfizer vaccine, there are two issues there. Firstly, there are allergic reactions, and these are quite acute reactions, as you might observe, for example, with antibiotics like penicillins or from a bee sting, and they can be anything from a hives type reaction, which is about 1 in 20,000, to a severe allergy referred to as anaphylaxis, which is about 1 in 200,000 doses. On the plus side, first of all, no one's been known to die from this reaction, even if it's been severe. It's a very short-term thing, so you get the reaction, you get treated, it's all over within an hour, you go home and you're completely well. Secondly, has been reports since the vaccine rollout of cardiac inflammation. So the term is myopericarditis. Again, about 1 in 37,000. It's mostly mild, and it's almost completely confined to men under the age of 25. And as of this week, globally, there's been 1 death reported. Although when you talk about heart inflammation, that can be a bit scary for some people. The reassuring thing is that the average duration of the illness is very, very short, a couple of days. And the vast majority of people who are hospitalised spend only a day in hospital. Importantly, COVID can also cause this type of illness, this heart inflammation. And about 1 in 9,000 people who get COVID will have the same problem. So with every medicine, every medical intervention, there's always needs to be a discussion with patients about the potential benefits and the potential harms. So what I've done here is sort of do a bit of a hypothetical. I'm not an epidemiologist, I'm not a mathematician. So these are my back of the envelope calculations. Looking at the benefits of the AstraZeneca vaccine in the top couple of rows, and then the risks and how that translates to serious harm, in particular death. So in the February to April period in Sydney, we had very, very little community transmission, at the most 1 a day. So if you look at we were unvaccinated at that time. So that's the white column. So no vaccines, 1 case a day, about 180 cases of COVID over 6 months, which you'd expect to translate to maybe 2 deaths. Of course, if no one's getting the vaccine, no one's getting the clots and no one's dying from it, which is 2 deaths overall. A lot of people said to me, well, Andrew, there's no COVID circulating. Why get the vaccine? You can't do better than 0. And I said, yes, that's true. And if we'd vaccinated 80% of Sydney at that time, we would have had, of course, less COVID. We probably would have had no deaths. We would have had about 50 cases of clotting, and maybe 3 or 4 people would have died from the clots. So 2 versus 4 in a population of 5 million people means that the outcome would have been about the same. But there's a really important assumption here that I think was not communicated at the time. It assumed that there would be no further COVID outbreak. And I don't think any of our leaders were brave enough to stand up and say, there will be another COVID outbreak. So a no vaccine approach was only ever going to be safer or as safe if there was never another COVID outbreak. So of course, we've had one. And so in the right-hand 3 columns, I've attempted to sort of model what might have been expected to happen with an outbreak. In the absence of a vaccine, and I just arbitrarily made up 100 cases a day, you end up with 18,000 plus cases over 6 months, and about 270 people die. Nobody dies from the vaccine. You end up with 270 people dying. With the vaccine, with 80% coverage, you reduce the cases by 80%, you reduce the deaths by 80%, but you cause a few vaccine-related deaths. but overall you end up with far, far fewer deaths overall. In fact, what we've observed is in the blue here on the right-hand side, as of 2 days ago, we've had 20,000 cases. So we've already reached my mythical 6-month projection, and we've had 90 deaths. The vaccinations was only going to cause fewer deaths if we had less than 650 cases ever. In other words, anything apart from the smallest outbreak was going to be, it was going to be better to vaccinate the whole population. So let's look at the impact of vaccination in Australia. On the top is, in the blue, are the cases we've observed over the last 1.5 years, and on the bottom in grey are the deaths. In the unvaccinated population, with this surge here in the middle of last year with the Melbourne outbreak, there was about a 4% death rate. So far, we've actually had more cases in the latest outbreak in New South Wales, but the death rate has been 0.3%. So the death rate now is 93% less this year than it was last year. Is that due to the vaccine, when we've only got about 30% of the population fully vaccinated? Well, that's probably, I would guess that that's partially contributing, but of course there are other reasons. We've got better treatments like the antiviral drug remdesivir. We have dexamethasone as an anti-inflammatory, and importantly, we've got far better isolation of residents in aged care facilities. How does that compare to other countries? So in the red boxes here, again, I'm showing you on the top the cases, and on the bottom the deaths. The first red box for each country is their first wave, and then there's the second wave, there's the second pair of red boxes. On the left-hand side of the figure, the slide is the United Kingdom, in the centre is the Netherlands, and is the right in Israel. So these countries have far higher vaccination rates when they entered their second waves. And of course, they had approximately 10% of their population that actually had COVID. So their immunity was 70% plus versus our 30%. And in each of these 3 countries, the death rate with the second wave was 80% lower in the UK, 90% lower in the Netherlands, and about 57% lower in Israel. There may be reasons why Israel's been a bit different to other countries, but it does encourage me to think that if we do get up to 70% immunity, then we can have much lower death rates for longer periods, even though there are more cases around. So how are we going in terms of vaccine uptake? Australia has about 28% of its population fully vaccinated, and we're only just slightly ahead of the global average of 27%. On the right-hand side, it compares Australia with our OECD compatriots, if you like. And on that metric, we're coming 33rd out of 38 countries. So that's us 5 from the bottom. The dark green bar, so for each country, the dark green represents the population that has had both vaccines, whereas the light green represents the additional people who've just had one vaccine. No country has reached 80% dual vaccination. 2 countries have reached 80% single vaccination, which is Portugal and Iceland. And about 10 countries have got 70% plus for the first dose, but not for the second dose. So these countries are up to 6 months ahead of Australia in their vaccine rollouts. And what's going to be critical for all of the countries is, the first 50 or 60% is going to be easy. It's going to be the next 20 to 30% that's going to be a lot harder because of issues such as hesitancy. So where are we up to in Australia? As of yesterday, being the 1st of September, the politicians report what's in the red box, right? So 59.6% of Australia has had its first dose. It's now just on 70% in New South Wales, and in the eastern suburbs of Sydney, it's 64%. But that's the first dose in eligible people, which is adults over at least age 18 and above. What we need, of course, is the second dose into everyone, including children, and that's in the green. So we have 30% of Australia fully vaccinated, 30% of New South Wales fully vaccinated, and 35% of the Sydney's eastern suburbs fully vaccinated. On the right-hand side is vaccination by age group. This is the national data showing that for all age groups above the age of 60, that at least 70%, and in fact almost 90% of a few age groups have had their first dose, but no age group has had 70% of its second dose. And you can see for the multiple reasons you might guess at, that the younger you are, the less likely you are to have received a first or a second dose. So vaccine hesitancy is something that the University of Melbourne does a national survey of every 2 weeks. And here's the responses to say that I'm either not willing to be vaccinated in the dark blue or don't know in the light blue over the last year, almost the last 12 months. Currently, across all age groups, about 10% of people say they won't be vaccinated, and another 10% of people say they don't know whether they'll be vaccinated. That proportion is far higher in younger Australians, 18 to 44, and much, much lower the older you are. The main reasons are somewhat nebulous. People talk about concerns about effectiveness, safety, and a general lack of trust. What about mandatory vaccinations? So 6 months ago, this was sort of anathema. Politicians said it can't be done, which in my experience just means that they don't want it to be done. But in fact, quite a few countries have, as shown in the green, have said, yes, these groups will have mandatory vaccination. In fact, in Indonesia, there's universal vaccination and a fine for refusal. What we have in Australia at the moment is a policy of mandatory vaccination for quarantine workers and aged care workers, with hospital staff all being required now, as of last week, to be fully vaccinated by the 30th of November. And different countries have taken different policies. The Canada and the United States have no such policies. So this is where I get on my soapbox for a minute and sort of shake my head in dismay, because I've always thought that there's been another way. If you think since May 2020, all coronavirus entered Australia from overseas via quarantine. There was a really important study done, reported a few months ago, where they surveyed by nasal swab, and if anybody's had a COVID test, you'll know what I'm talking about, 20,000 travellers who were transiting through Qatar, through the airport at Qatar. And they looked at 10,000 people who were fully vaccinated at least 2 weeks before they ended up in the airport, and 10,000 people who had not been vaccinated. And the frequency of having a positive PCR test in the fully vaccinated was about 80% less. So if you were fully vaccinated and you went through and you came to Australia, there would be an 80% chance, lower chance, that you would bring the virus with you. That means there would have been an 80% lower chance that the limo driver would have got infected, which is a bit dismaying because it would have been a completely free and easy intervention for Australia to have adopted. So what will our new normal be? Hopefully we will get up to vaccinate all of Australians, including children, particularly those at greatest risk of death and in those who are most likely to spread the virus. I haven't had time to discuss it much. There isn't great data, but it's highly likely we'll be getting booster vaccines something like every 6 to 8 months. There'll be fewer restrictions for the vaccinated, and that's just beginning now. I think there'll be even more mandatory vaccinations, particularly in workplaces. What we really need a blood test that can tell us who is immune and who isn't. We will get better vaccines. So these are just first generation vaccines. We'll have vaccines that are effective for longer, that are effective against new variants, that have fewer side effects, that only require one injection and not two. And there is already a study going on looking at combining the COVID vaccine and a flu vaccine in a single injection. Where will we end up? Hopefully we'll stop counting cases because that won't matter so much. And what we will continue to focus on is counting hospitalisation and death. I don't believe we'll ever eliminate coronavirus with vaccination, but we will hopefully eliminate most COVID-related deaths.
That was really informative. Thank you for that. And I mean, things have moved along so quickly with this pandemic. In some ways, it's actually still mind-blowing to me that the vaccines have been developed so quickly and that they are available. And it's interesting that they, as you said, the next generation vaccines will hopefully last a bit longer, because I actually wasn't aware that after 4 months and 6 months, the efficacy was dropping. So the booster point is an interesting one.
Well, yeah, the US has just announced that people who've had their second injection 8 months ago or more will be eligible for a third. And a few other countries are starting to sort of head down in that direction. There are formal clinical trials going on looking to see whether that third shot will protect against illness and hospitalisation, but those studies haven't been completed just yet.
And the 70% to 80% point. So I'm going to ask Kerryn now to take us through the debate around the Doherty modelling, which there's been a lot of debate about this Doherty modelling. The government is focused on it. The interpretation of it by the federal and state governments is a little bit confusing. At present, the federal government's targets for easing restrictions are based on that modelling, and they are saying that restrictions can be lifted when 70 to 80% of eligible people, that's adults, I think over 16 years of age, are fully vaccinated, which on current rates, they're expecting to be towards the end of October or early to mid-November, a bit later in some states. But the question is this actually going to be sufficient, or do we need to be talking about 70 to 80% of the entire population, including children? So the debate around this is a bit confusing, and it's just something that I'm hoping, Kerryn, you're able to just help us untangle a little bit.
Thanks, Kath. I'll do my best. As you can see, there are a lot of numbers to process from Andrew's excellent presentation there, and I think it's really important that we have a look at that whole numerical and statistical landscape so we can have some understanding of what we're all trying to grapple with in terms of, you know, from my perspective as a GP, trying to walk people through their decision algorithm as to which vaccine is the best for them, and you know, a whole lot of other questions that people have about vaccination and about the restrictions and about their concerns. And so it's really important that we continually have that updated analysis. A lot of people are talking about this Doherty modelling, and it was an exercise that was requested by the federal government of the Doherty Institute. And what they were asked to do was to formulate a number of scenarios. And the scenarios were based on what would happen if you eased restrictions at a particular level of vaccination of the general public. And they looked at 50%, 60%, 70% and 80% of people over 16. And they did some separate modelling for over 12. And they came up with an answer that if you eased restrictions at 50 or 60%, you are likely to get an uncontrolled epidemic. If you eased restrictions at 70 or 80% of the eligible population over the age of 16, you could expect a certain number, in the way that Andrew's done with his assumptions and his modelling there, a certain number of hospitalisations and a certain number of deaths. It wouldn't be zero. And so there had to be a political decision made in a way, and also a public health decision made about the tolerance for hospitalisation and death. But there also had to be, and there still clearly needs to be, modelling done that compares those figures with what our capacity is as a health system to be able to cope with that number of people who are seriously ill, who require a high level intensive care over a prolonged period of time and who may or may not recover. And so we're looking then at the pressure on the health system from COVID infections, but we have to understand that in amongst this, there is a whole lot of nuance. One of them is that this modelling doesn't look at what happens to children who are under 16 or under 12, depending on their eligibility for the vaccination. And we do know from overseas experience with the Delta variant that it does affect children. We do see hospitalizations, we do see long COVID, and we can see deaths in children. And so that needs to be included in the modelling. And at this stage, we don't have a vaccine available for children who are under 12. It's difficult for parents to get a vaccine for children under 16 at the moment. And indeed, adolescents and younger adults are finding it at the moment quite difficult to get appointments in the short term. So there are those issues. The second issue, it has to do with the hospital system and the health system, has to do with the fact that COVID is not the only thing the healthcare and hospital system treats. And so what we have to do is to see what the impact is, and the AMA was just talking about this in the last day or two, what the impact is of a higher number of people requiring hospital care, intensive care, or who develop chronic long COVID, which Andrew alluded to earlier, what impact it has on the health system for people with other diseases like diabetes, heart disease, cancer. We've already seen the closing down of breast screen services in New South Wales temporarily, but what that means is that there will be women who have a delayed diagnosis of their breast cancer. We've also seen the suspension of elective surgery in some private hospitals and in public hospitals, and that will mean that people who have necessary but not necessarily urgent need for surgery will not get their operation in the foreseeable future. So when we're talking about easing of restrictions, we will talk about greater pressures on the hospital system. And indeed, when we're talking about, let's say, 70%, 70% is actually only 70% of 80% of the population. So that's 56% of the population. Even at 80%, it's 80% of 80%, which is 64% of the population vaccinated. So when we're talking about 80% of the population that will provide protections, the modelling that we're talking about is really only talking about 56 or 64% of the population. And what does that mean to the vulnerable populations? And the third point that I would make about this modelling is that if we're talking about the percentage of the eligible population versus the percentage of the total population, we're not talking about the percentage of vulnerable subgroups. And the vulnerable subgroups are people like our jail population, for example, people who are homeless or at risk of homelessness, people who have disabilities, aged care, Indigenous communities, and more. So we need to be seeing, and Kerry Chant made this comment the other day in a press conference, that she would like to be seeing that 80% number in every one of those population groups being the threshold, not just 80% of the total population, because it's quite likely that we may well see 90% or more of the eligible population in places like the eastern suburbs or other areas of Sydney. But in other pockets of Sydney, we may not get anywhere near that, but it could still bring the percentage up to close to 70 or 80% of the total population. So those are the kind of nuances in the statistics and the figures that we're talking about. And then, of course, we've got all of the individual concerns that people have that are quite specific, where they talk to their GP, where they might be referred to Andrew for a more detailed discussion of their immune system and their situation, or where somebody has conditions like existing coronary artery disease, heart disease, where they might have an immune condition, where they might have a neurological condition, and they will need specialised advice from their specialist. So it's not just a matter of, let's look at a 70 or 80% number and then we can start easing restrictions and everyone will be happy. The next thing that I would like to make a point about, and I think this is a really important one, is that there are mental health consequences to these lockdowns. And so there has to be a nuanced approach. but where there is a mental health consequence to people losing jobs, not having an adequate income because there hasn't been financial support from the state or federal government in the same way as it was provided last year. And so people have felt the need to have to go to work and not stay at home when perhaps if they had financial support they might have. We're seeing people who are dislocated from family, from their usual social supports, people who are in accommodation where it's perhaps crowded or it may not be a safe home environment for them. These are some of the consequences of the mental health issues that are surrounding extended and profound lockdowns. The other issue is the mental health consequence of people being frightened of COVID. They're frightened for their children. They're frightened if they're not vaccinated and there's easing of the restrictions, that if they're one of that 20 or 30 or even close to 40% of people in the population who are not vaccinated when there's easing of restrictions, that they, in their unvaccinated state, might come across COVID and be one of those statistics that we're talking about. So those are some of the issues that we're grappling with at the moment. The numbers are important, the numbers matter, transparency matters, but we have to be thinking about not only those numbers of hospitalizations and deaths and people with long COVID, but we also need to be thinking more broadly about its impact on the health system and on the mental health of everyone.
Yeah, thank you. That was awesome. You covered a lot of points there. I mean, one of the questions that I had was on the issue of vaccine equity. It's being talked about now that, some people have got better access to the vaccine than others. Is it fair to open up New South Wales if, city of Sydney might have reached 70%, but not in the regions? What is that going to mean for people who live outside of the city or in certain parts of the city? Kids that are younger who may not have had access to the vaccine and as you say, other groups that are vulnerable. The question I've got is what should the federal government be doing to improve vaccination rates amongst those groups? Because it is that we know that there's a problem with supply, but how can they ensure that we're not just opening up once we tick a box and hit a figure? How do we protect those vulnerable groups? To either of you, if you want to answer that one.
I have a very high regard for the public health people in New South Wales. I've been lucky enough to sit on a committee chaired by Kerry Chant for the last 10 years. Relating to controlling the HIV epidemic in New South Wales. She's really smart, she's really tough, and she knows what needs to be done. She's been working in public health for 30 years. Maybe I shouldn't have said that, but so I have no doubt that she's not a simple person who thinks that there's one simple solution, right? I heard the word nuance a few times. That's the sort of person. I think she's very reflective. I think she will do, any response will be a graduated response. Most jurisdictions in Australia, actually, the Chief Health Officer tells the government what to do. I'm advised, although I'm not a lawyer, that in New South Wales it's the other way around, that the governments listen to the Chief Health Officer, but the Chief Health Officer can't actually dictate the policy. Nevertheless, I think that we will see a series of gradual easings of restriction, not a wholesale Freedom Day type approach. And you wouldn't do that if there were groups being left behind. So I think that they will be very keen to ensure that whatever target it is, that we reach that across the state and that it's achieved in all age groups, it's achieved in risk groups before, all the barriers are taken down. And I don't see all the barriers being taken down for quite some time. And of course, it's up to society what the key barriers are, right? So the barriers for me as somebody who has adult children, although one of them's locked in a 5x3 dormitory in Canberra University. The other one's in his 8th month of lockdown in Melbourne. And there's another one travelling around Western Australia who's wondering what all the fuss is about. For those, I have family who have, my sister-in-law's a primary school teacher. She's got 3 school-age children. For her, it's a very different sort of experience, right? And so we need to make sure that all the groups are having their principal concerns addressed, so that when a barrier is taken down, it's received positively by the community, not with a rebellion.
I think that the sort of concern that I've got is around the conflict between what's happening at the state level and at the federal level. So we've heard the federal treasurer and a number of politicians are very keen to apply, I guess, as much pressure as they can on the states to reopen as soon as possible because of the economic impacts of lockdown. And that needs to be weighed against the public health risks of opening up too quickly and what's happening within the state governments, and particularly in New South Wales and Victoria at the moment, where we've got the most people in lockdown. So I guess it's not clear to me that the federal government are as focused on the vaccine equity issue and making sure that vulnerable groups are protected. It seems to me that they're pushing very hard to, as soon as we get to the 70% number, push the button and off we go. So I guess we just got to keep a very close eye on how that develops, and it's all based on the assumption that we actually reach that 70% rate, of course, when expected, which may not happen if we've got issues with vaccine hesitancy and supply. So
I think hesitancy will be a more important issue until we have an oversupply of vaccines, right? And that's when, at the moment, the equity issue is there's just not enough to go around, because unfortunately they didn't order 50 million doses from 5 manufacturers in July last year, right? You diversify your investments. That's what most businesses do. So given, we've been playing catch up for the last 12 months, once everyone's got access, then you can start focusing on all the sort of groups that are being left behind. And, well, some groups will choose to be left behind. I have a close neighbour, lovely people, fervently anti-vaccination, will probably choose to lose employment rather than be vaccinated.
Andrew made an important point, Kath, and that was about the fact that there are going to be other vaccines and other treatments that are developed, and I think that the speed with which we saw vaccines developed is like nothing we've ever seen in vaccine technology. I don't think certainly in my professional memory, which is getting longer every day, So a year and a half ago, I don't think we could have anticipated that we would have at least 4 or 5 different vaccines globally, and the choice of between 2 and 4 coming up in Australia at this stage. So from that point of view, we are very lucky to be at this stage of medical technological development. The fact that there's been that speed of development, it's also quite likely that all of the modelling and all of the assumptions will need to be changed as technology develops as well, because there are places around the world, the researchers who are working on inhaled forms of vaccine that protect the respiratory system. There are new treatments that are developed and are going to be developed, which could well change the whole scenario too. And on the other hand, in terms of the risk part of the equation, is that we are going to see the emergence of vaccine-resistant variants, and that will mean that the development of the treatments needs to happen in parallel with the development of new prevention strategies, while we keep in place sensible public health measures like mask wearing, hand washing, physical distancing, and perhaps even targeted lockdowns as time goes by. So this is going to be, this is a long-term marathon. This is not a sprint. And I think that what we're hearing about modelling is a snapshot in time based on assumptions of what's happening right now. But that landscape is and will change continually.
Yeah, and just the pure psychological aspect of it as well, that we're now coming to grips with this major pandemic that's been in our world for 18 months or longer now. And what that means in terms of what we've had to accept in terms of not being able to travel, not being able, people being very sick and ill and dying, enormous numbers of deaths. Luckily not so high. The death rate in Australia has been mercifully low compared to other parts of the world. But one of the things that the conversations that I'm seeing happening in the UK and here as well now is we know that this is not going back down to zero and it's going to be with us for the long term. So what is the acceptable rate of death? That is a question that we have to ask ourselves when we're talking about opening up, unless we are going to stay in lockdown forever, which even then you're still going to have deaths. It's a really difficult topic to discuss and think about, and it's not something that my generation is certainly used to having to talk about something so existential and so serious. But how do and thinking about the mental health impacts that are very real and very severe on everybody, and increasingly on kids who are now been out of school for some time, and it's a really big issue. How do we approach the task of working out what the acceptable death rate is? What's the answer to this? I mean, someone pointed out to me the other day that a certain number of people die in Australia every year from all sorts of causes. We've got a certain, I don't know what it is, 400 or 500 a year or something more than that die from the flu every year, and we've accepted that for a long time. So what's the acceptable rate for this particular disease to get us back to some sort of normality?
If you want to bring a new medication to Australia and you want the government to fund it, a drug company will do a series of studies. Governments don't develop drugs, companies develop drugs, right? So you bring a new drug in, you demonstrate that it's effective, and the second phase to get it government funded is to say that it's value for money. And we have health economists whose bread and butter is to decide how much money a medication or an intervention is worth to add a year of life. And the sort of jargon term is called a quality adjusted life year, which sounds a bit awful putting a dollar value on life, but that's exactly what health economists do. Because if you're a government and you've got so much money to spend on health, you want to make sure you get the most value out of that money so you can help the most number of people survive the greatest number of years. Those sort of exercises, I mean, I know nothing about how those are done. They're doable, but of course, it's not just survival that you would want to look at, right? You need to look at, as Kerryn said, the other health issues that are going on in the background. So the people who can't get their breast screening done, they can't come in for bypass surgery, they don't go to the doctor for a year because, I'm anxious about leaving the house. And so in the first 6 months of this year, we had a normal hospital system, but in fact, people were coming in and staying twice as long because they were sicker than they were in 2019, right? So we had people, instead of the average length of stay in a hospital being, 5 days or something, it was about 10 days. And so we were constantly overflowing with queues of ambulances waiting to get in. There's of course, all the mental health issues. There's clearly big employment issues. Unemployment is a medical issue, right? It's poverty, is ill health, right? So you need people who can evaluate this, making sure all of those things are considered. I think such people do exist. It would be great to see that sort of modelling.
It's an enormously complex area, isn't it? And it's very ethically difficult area. Certainly I don't have any clear views or answers on it. It's just something that I think we're being faced with, and people are having, I mean, it was one of the questions that was asked in the Guardian Essential poll that I mentioned before, how many deaths would be acceptable as a result of opening up. I think it was something like 61% in Australia. I'll just find it. 61% would accept fewer than 100 deaths per year as a result of restrictions being eased. So it's not something we've got a huge appetite for.
The Doherty model at lifting restrictions at 80% predicts about 1,800 deaths a year.
Mm.
So I'm not sure the Guardian asked the right question.
Yeah, that's right.
Well,
that's right, isn't it, Kerryn? That was the sort of number.
Yes, that same poll that you're talking about, Kath, also had a figure that said that, and you've probably got it there in front of you, that only 12% of people said that they would accept easing of restrictions that meant more deaths and hospitalisations. So I think the question also comes down to, are we talking about deaths as a number, or are we talking about people you know? And if people start thinking about, well, this could be my parent, my partner, one of my children, it could be one of my friends, then the numbers have a very personal element to them. So on the one hand, you could be a health economist talking about qualities, but on the other hand, you know, if somebody's thinking, well, hang on a second, I don't want to risk my parents or one of my loved ones or my children or my friends to sacrifice them to this virus, and just because we opened up too early. So it has to. When you say about what's acceptable, people are really putting their minds to this. It's not. I don't think people are being in any way flippant about this. People are really thinking very carefully about what all of this means and have been prepared. You know, if you follow the social media chatter about this too, there are some people who are, clearly resisting any form of lockdown, but the vast majority of Australians are doing what they need to do for community safety, and they're really carefully thinking about the risks to themselves, their family and their community of easing those restrictions at particular levels. And that's why I think the Doherty model is important, because it actually does put some numbers based on assumptions to those actions that government might take.
Yeah, no, that's right. There's a lot of thinking to be done. Yeah.
If I've sounded a little bleak, and sometimes I feel a little bleak, I think by the end of the year we will have turned the corner. I mean, this is it is a race. It's a long, slow race. It'll be a 10-year experience. Currently, it's sort of World War III, right? You have the weapons you've got to fight the enemy that you have, and you've got no choice. I think Australians have been remarkably positive in their response and their willingness to do the right thing. It's a vanishingly small fraction who want civil disobedience over this. Yeah. Sure, there is. My main concern are the 10 to 15% who say, as of today, that they won't be vaccinated. Hopefully, there's a lot of word of mouth. I know somebody, they had the vaccine, they were fine, so I'll go and get it too. And so I would encourage everybody who's watching this video, right, if you've had the vaccine and you've had a good or a bad experience, to talk to people about it, because that's going to be far more persuasive than social media or the television.
Okay, well, look, we're almost out of time. Maybe just one last quick question on quarantine. From an economic perspective, the lockdown is expensive. It's costing about $1 billion a week for a major city to be locked down, which is not insignificant. There are still Australians trying to get back to Australia, and a lot of Australians who would like to leave Australia but can't, or are concerned about being able to get back in. Given the difficulties experienced globally in containing the spread of COVID and the prospect of further variants emerging, if we're going to reopen our international borders, shouldn't we be building fit-for-purpose facilities now to enable Australians to feel confident about international travel and also to promote tourism back to Australia?
Absolutely. We should have been building purpose-built quarantine facilities a year ago. We're way behind schedule on that. As Andrew said, this is going to be around for a long time to come. And if we are going to be bringing people in from overseas to areas where there are high numbers of infections, and there are a few things that we need to do. Andrew mentioned one of them earlier, but we need to be rapid antigen testing people before they get on a plane to come to Australia. We need to be insisting on people being vaccinated, and we need to have quarantining here in Australia that is fit for purpose. You can't have people in hotels with inadequate ventilation principles for 2 weeks in a room where they can't open a window, where there is no ventilation, and where they've got no ability to get any fresh air. We have to be looking at proper quarantining facilities. And I think it's really, we're at a time where I think we actually need to start looking at issues like ventilation. I mean, we've had this crazy debate for most of last year about whether this was an airborne pathogen. I mean, that should have been settled such a long time ago. And then that moved on to the principles of ventilation. We even had a debate for almost a year about mask wearing. I mean, I was nearly tearing my hair out at one stage thinking it's just so obvious that this is an airborne pathogen, and if you wear a mask, it'll reduce your risk. And yet, you know, I was having these crazy, frustrating arguments with people. Anyway, I think we've gotten to the point where it's acknowledged that it's an airborne pathogen. It's acknowledged we need ventilation standards. It's acknowledged that we need to wear masks when we're likely to be in contact with other people. So we've come a fair way in terms of that debate as well. But I think we need to start drilling down into the real nitty-gritty about how we can reduce the influx of infections from overseas if people are going to be allowed into Australia in greater numbers than they are at the moment. Bearing in mind that our borders haven't actually been closed, we've had a lot of people still coming and going from Australia for business and compassionate and other purposes. But we need to, you know, things like the quarantine workers who weren't required to be vaccinated, who weren't required to wear masks. So that was something that had to be tightened up. So, you know, and for quite some time, we were looking at people coming in and out of airports without a mask in sight, for example, without any checks on them at all. And so, you know, any sort of slight chink in the armour, it's going to be exploited by this COVID virus. So we have to make sure that we apply a precautionary principle, we identify where the problems are likely to be, we tighten up anywhere that needs to be tightened up, and we reduce the risk incrementally in that Swiss cheese model.
I agree. It's very frustrating to watch things that you think should be common sense solutions not being rolled out with urgency. But anyway, we are where we are. Well, we're going to wrap up there. Thank you very much to both of you for the time you've given us today. It's been really helpful, and I know that there's going to be a lot of interest in this discussion. We have written to Dave Sharma following our COVID town hall. We sent him a letter and asked him some questions, and he has replied. We've got all that correspondence on our website, and we'll be following up with him again following this discussion. So obviously it is a developing situation. As you say, it sounds like it's going to be going on for a long time. So it has a really severe impact on voters, and people are watching to see how this will be managed over the next few weeks and months. So just to finish up, Voices of Wentworth, we're currently conducting a voter survey to find out what Wentworth voters care about, and we'll be publishing the results in a comprehensive report before inviting our current MP, Dave Sharma, and all other Wentworth candidates to participate in a public forum with voters prior to the next federal election. So if you're a Wentworth voter, please take 5 minutes to complete the survey, which you can find on our website. And the more responses we get, the better we know what people care about in our electorate. Keep an eye out as well for exciting details coming soon about a free screening of the new documentary film by Craig Recusel. It's called The Big Deal, and we'll be doing a corresponding online town hall event as well on the 23rd of September on the subject of integrity in politics. All of our previous events are available to watch on our website and YouTube channel, and this session will also be up there very soon as well. But for now, thanks for watching, and we hope to see you again soon.
Thanks,
Thank you very much to both of you.
Bye. Thank you.